Great. Thanks, Peter, and thanks, Anna Marie, for that great setup. Anybody who's read a heart failure paper knows it always starts off with the obligatory 5 million people with heart failure, 650,000 new cases a year, so we had to get that part out of the way. It's kind of at the point now where some of the journal editors are saying you really don't need to do that, but it's so hard to write a paper without thinking about that. So as Anna Marie set us up here, we're going to talk about acute heart failure from a trial perspective, and I'm going to talk about what we thought we knew and what we learned from recent trials. And before we get going, I also want to show that you can say learned. I learned that by putting this together. You can say learned or learnt. If you're British, learnt is okay. If you're American, learned is the way you're supposed to say it. That's one of the things I learned from putting this together. Disclosures, we're all pretty much involved in a lot of the trials that get done in acute heart failure, and we're all partners in crime. One of the really nice things about being on a panel with these guys is, as Peter said, we worked together for 10 years. A lot of the stuff that gets written, we write together, and a lot of the grants and industry-funded projects, we help steer them. So it's great to be on a panel with good friends and colleagues. So I was going to say that we're all excited today because we came up with a new drug that all emergency physicians want. I had this pronounced and I always forget how to say it. Furosemide, which is basically a combination of everything we throw at these dyspnea patients that come in the door. And this is what a lot of our colleagues kind of think about our approach to heart failure. We just throw it all out there, see what sticks, and let someone else sort out the problem. Reality is acute heart failure is something we see commonly and something that, as Anna Marie mentioned, we don't have a lot of new therapies. And in the last decade or so, there's been a lot of interest in trying to change that paradigm. And the reason why we don't have a lot of new therapies, we published this paper now 8 years ago. I can't believe it's been that long ago. And we've always put this slide up there that talks about the lack of targets of therapy. And that's one of the things that we don't know. What are the targets of therapy? What is the thrombosis? If you want to look at a parallel to ACS, about similar number of cases, heart failure and ACS a year. ACS, we know what to do. You go ahead and pull the clot out, and patients do better. And heart failure, we don't know what to do. You take some fluid off, you give some antihypertensive medication, who knows? There's no clear trial results that show benefit, harm, whatever it is, and there's not a lot of evidence. And so when we started writing this in 2010, that was true. And then a whole bunch of trials came out. And what had led up to that point in 2010 were a bunch of trials that were done after admission. And so people like us said, well, if it's acute heart failure, trials are all done after admission. It's not really treating the acute heart failure we know in the emergency department. That heart failure patient who we fix, and then the internist comes down and says, this patient doesn't have heart failure. They're not short of breath. And then they say, you didn't give them a diuretic. How could they have heart failure? So these are the kind of things that we were set up in the backdrop. Trials started getting designed, Ascend, Protect, that actually looked a little bit earlier. Said we're not going to necessarily wait until the patients come upstairs, but we want to get them within 24 hours. And most of the time that meant after they leave the emergency department. And so all of these trials that are listed here were essentially negative. None of these trials showed any clinical, clear outcome benefit. Everest, which Peter has done some work within the database, showed that you can get fluid off if you use tolvaptan, but it didn't improve specific heart outcomes that we were interested in. The only trial that actually showed a signal was Relax-AHF, which some of you may have been aware of, and it was the first trial that really targeted 16 hours of presentation or earlier. The median time to enrollment in that study was about 8 hours, 7.5 hours or so, so it was kind of in our purview. Now, that might seem like a long time for an emergency physician, but keep in mind that from the point when you identify a patient to the point where you actually randomize them takes a lot, because you have to go through all the inclusion-exclusion criteria, whatnot. And so this was great. We were all excited. We were at the forefront of acute heart failure. This is our time to be. And Relaxin was the it drug at the time. It's a drug that has several different effects. It involves endothelin-1 pathways. It involves nitric oxide pathways as well. And it showed a mortality benefit. And that's what everyone was so excited about. And it showed a mortality benefit out to 180 days. And the curves started separating within a couple of days of the therapy. So early on, if you got the drug for the first 48 hours, terrific. You did better if you got the drug. You did worse if you didn't. And the reason that we purported, or others purported, that this happened is because you interrupt this pathway of cardiac injury, potentially, right? By decreasing cardiac injury, you can improve long-term outcomes. So data with Relaxin versus placebo showed that patients were less likely to have troponin rise. They were more likely to improve their NT-proBNP, but it crapped out when it came to the final trial. So a 6,800 patient trial that was just, 68, was that the final number? Was recently completed. We were all involved in enrollment. In fact, our group, MROC, which Peter will talk a little bit about, enrolled more patients in the United States than just about anyone else. But the trial crapped out. It went nowhere. So where we're at right now is a long history over the past decade or so of a bunch of drugs and trials that have failed. And I'm not going to highlight each one of them because that would take longer than my 10 minutes of allotted time. But you can see here there's things like tezosentin and Relaxin, which we talked about in Relaxin. Diureties is another one, a recent Diureties analog that didn't work out in a trial called TRUE-AHF. TRV-027, a trial that we were leaders of called BLAST-AHF. Really, it's supposed to be pronounced blast-off. I was very happy when I came up with that title, but blast off. But that didn't work either. It didn't blast off anything. It just, it's sort of, these trials put the nail in the coffin kind of in this area of acute heart failure. So publications started coming out like this, and I'm going to walk you through this a little bit because these are really the lessons learned and what can we do about this. So Chris O'Connor, he is the outgoing president of the Heart Failure Society of America, the editor-in-chief for JACC Heart Failure, a really knowledgeable individual in the heart failure space who's been a great friend to emergency medicine. When we convened the AHA panel, the NHLBI group that we all spoke at, Chris was integral to having this. So we have good friends on the cardiology side that are working with us on this. But the questions come up. We've had all these failed trials. What do we do with this information? And is it over? Is this journey over? Are we just going to accept the fact that heart failure is a wash, rinse, repeat process? And you can laugh because I have no hair and I say that, but that's kind of the process, right? You know, the patient comes in, we fix them, they go home, they do whatever they're going to do, and they come back to the emergency department 30 days later. And we know these patients by name and by face and by whatever else. So part of the problem and something that we thought that we might have understood was the pathophysiology of heart failure. When you actually look at it, what causes acute heart failure? Well, there's a number of things that can lead to precipitation of heart failure. You can have acute coronary syndrome, atrial fibrillation, elevated blood pressure, infection. You can have worsening renal function. It's a hodgepodge of things, but it all presents with a similar thing, which is shortness of breath. And so we're left to take this dyspneic patient that we think has heart failure and sort it out. Reality is we've sort of divided it up into two groups. This idea of ejection fraction doesn't really play so much into how we think as emergency clinicians. What really, we've divided it up into this idea of cardiac failure versus vascular failure. Cardiac failure, Sean's going to talk more about this, is more of a fluid overload type patient, the one that we're used to seeing. You push on their tibia, your thumb sinks into the interphalangeal joint. You know that patient's got a lot of edema. That patient's got extracellular fluid accumulation, either from water intake, excessive water intake, worsening renal function. A lot of it gets stored in a splanchnic circulation and gets redistributed. But there are ways to deal with this diuretic, and we're still sorting out the optimal dose and timing, and again, Sean's going to go over that. On the other side is the vascular type, and this is the one that really is our purview as emergency physicians, and ones the cardiologists either A, don't think really have heart failure, because a little elevated blood pressure, a positive troponin, and a positive NT-proBNP in any other world equals heart failure, except when your cardiologist wants to not admit that patient. That's not heart failure. In any event, we've talked a lot about this group, and this is what a lot of the recent trials have targeted, this sort of hypertensive phenotype, this vascular shift, this idea that it's not excessive fluid accumulation on the inlet end, on the preload end, it's actually excessive afterload that's leading to a mismatch between the arterial circulation and the ventricle. I won't say it, Sean, I promise. And so we've worked a lot in this space. And our team has done a lot of work with really high doses of nitroglycerin. If you guys haven't been aware of this work, we started doing this a decade ago, giving 2 milligram boluses. We recently published on our experience that says in a hypertensive heart failure population, if you give really high doses of nitroglycerin, you can decrease length of stay and not put patients in the ICU. And this is probably an artifact of giving it by bolus as opposed to infusion, because you give an infusion that buys someone an ICU admission. And here we're saying if you give it by bolus, you still get some of the clinical benefit, which is lowering blood pressure, affecting that phenotype, and not requiring an ICU length of stay. So we looked at the hypertensive heart failure population, but the Europeans have been looking at this a little bit differently. And they've shown benefit with vasodilators over inotropes. Inotropes always do the worst. This is just a registry, the ALARM-HF, not a clinical trial. But they basically show when you give vasodilators versus diuretics, the patients who get vasodilators do better. Now, you would all say, yeah, that's because they're hypertensive and the hypertensive patients do better. But what they actually found is that the vasodilators benefit the most in the patients who are borderline hypotensive, people we would not even ever think about giving vasodilators to. And so the Europeans include in their guidelines to give early vasodilation to these patients over here. So to me, this tells me that we don't really know what the heck we're doing, right? Because we give a lot of nitroglycerin to this hypertensive group down here, and they tend not to die as much in heart failure. We kind of know that. But the mortality benefit is to the patients that we don't even think about giving nitroglycerin to. Now, others have shown that vasodilators do nothing. Right? You mixed all the patients together, vasodilators in addition to diuretics, vasodilators at all, nitrates at all, don't provide any benefit. And maybe it's not that we don't know the phenotype of the patient because they have elevated blood pressure or not. It's that blood pressure is a complicated thing. So by looking at blood pressure, we're looking at the wrong piece of information. Blood pressure is a mix of vascular resistance and cardiac index. And maybe if we look at how the heart pumps and the function of the heart versus vascular resistance, we'll get a better indication. As you can see here, these are data that we put together with Rich Nowak using a device, basically does non-invasive hemodynamic monitoring. And these lines right here show where vascular resistance is high or low, or cardiac index is high or low. And you can see it's a mixed bag. And these patients generally had elevated blood pressure. So you have people with that high vascular resistance that probably would benefit from a vasodilator, people with low vascular resistance that probably wouldn't, but you wouldn't know just by looking at the blood pressure. So it is true we don't know the pathophysiology, but we have to think about it differently lest we continue to not know. The other thing that was discussed is whether or not 24 to 48 hours of therapy is likely to provide any prolonged benefit. And this is really an area of big interest. Can we move the needle on post-discharge benefit? Well, I would say kind of mixing it together that we don't know the pathophysiology, that's led to this problem because we look at these endpoints where maybe the therapy was not properly aligned with the pathophysiology of the patient. So I mentioned blast off briefly before, and this was a drug looking at TRV-027, a study looking at that drug, which is a combination of an angiotensin receptor inhibitor and an agonist for cardiac contractility. And basically, when you gave varying doses compared to placebo, you got blood pressure lowering effects, but there was no benefit in blast off. But when we actually looked at the patients who had elevated versus lower blood pressure, you saw a greater blood pressure decline in those who had elevated blood pressure versus those who didn't. And you actually saw a signal that mortality might be better in those patients who were at elevated blood pressure. So what this kind of says is that maybe it's not so much we can't change 48-hour outcomes, 180-day outcomes or whatever, protracted outcomes within a 48-hour period. It's that if we don't target the therapy to the pathophysiology, we can't change anything. And that's kind of another thing that I think we've learned. And Peter's going to talk about this a little bit more. Maybe it's the endpoint that we're targeting. Maybe the endpoint that we typically use, which is 3 days or 4 days in hospital, as opposed to is the patient better, is not the right endpoint. Maybe actually looking at full decongestion by showing that you've alleviated lung water content is the way to go. And these data basically show that you have a much higher risk of death or heart failure readmission if you still are congested by ultrasound when you leave the hospital. So that's another thing we learned is maybe we need to rethink about what our endpoints are. And wrapping it up here, Anna Marie mentioned this, and this has pretty much been Sean's existence for the last couple of years. It's hard for us to do anything post-discharge if the patients in the system don't do anything post-discharge. So we all know the things that change trajectories in heart failure survival and outcomes are all the guideline-directed medical therapy that we get people on, ACE inhibitors, beta blockers, spironolactone, eplerenone, whatever it is. And so it's really all about that transition of care. And we're going to hear a little bit more from Peter next about guided heart failure, which is Sean's study that's looking at this very idea. How do we get people to get that better transition to care? And if maybe we think about it differently, that it's not a drug or a new therapeutic that we need to do, it's just better alignment with existing therapeutics that will lead to the outcome benefit we want. And then finally, at the end of the day, it's about a patient. And so maybe we should talk to the patients and get them involved in the care that we're delivering. And so this is something that we've been working on, incorporating patient and caregiver experiences into clinical trial design. In guided heart failure, the endpoints of the trial were changed by talking to patients, including them in the design of the trial. And while it was really fun to get this paper published, perhaps the best part was the editorial that accompanied it that said, when should we get patients incorporated? It said early and every time, essentially. And so that's kind of where we're at. These are the lessons that we learned, at least that I feel like I've learned or learned going through this. And now we're going to hear a little bit more about what's next for acute heart failure research.